Hi, welcome back. Now, you're working, I guess, in an emergency department, right? And so you're taking care of one patient that's retaining water so much that their brain starts to swell. And then you have another patient that's losing water so fast, they are heading straight towards hypovolemic shock. Now, both conditions involve ADH, which is antidiuretic hormone, but they're complete opposites. And if you mix them up, you can seriously harm your patient. So today I'm going to talk about SIADH versus diabetes insipidus. So hopefully they'll finally make sense. And with that, you'll be able to recognize it fast, answer NCLEX type questions, and really know what to do as a nurse when you're having these patients. So welcome to NurseEdScholar, where we just don't memorize, we understand. And this is another video in the endocrine critical series. And today, like I said, we're going to break down one of the most confusing comparisons in nursing. So let's simplify it. Now, before we go into details, let's lock in one core concept, okay? Now you have anti-diuretic hormone, and that's ADH. It tells the kidneys to hold on to water. So think of it, anti-diuretic. What do diuretics do? They make your patients urinate. But if it's anti, that means they're not urinating. So they're holding in the water. So here's the key. SIADH, which is syndrome of inappropriate antidiuretic hormone. But it's so much to say, so we say SIADH. They have too much ADH. And then diabetes insipidus has too little ADH. So let's kind of say that again. SIADH means that the water is staying into your patient, staying in their body. And then diabetic insipidus, or diabetes, I'm sorry, diabetes insipidus means that the water is leaving the body. And that really explains everything. So let's look at that one more time. SIADH, what are the first two letters? SI. So if you can remember soaked in, that means that the patient is retaining water. And then with diabetes insipidus, it's DI, the first two letters in diabetes, or well, diabetes insipidus, DI, right? DI, dry inside. That means that everything is leaving out of your patient's body, all of the water. Okay, so now let's compare them side by side. SIADH, too much ADH. Water is retained, blood becomes diluted. Why is that? Patient is holding on to all of the fluid. It's going to dilute the blood concentration. Diabetes insipidus has too little ADH. Water is lost, so the blood becomes concentrated. So if they have too little ADH, that means the patient is urinating a lot, they're releasing a lot of fluid, so the blood gets concentrated. Okay, let's look at it one more time. SIADH, too much water inside. Diabetes insipidus, not enough water inside. And this is why one causes swelling of the brain. If you have too much water inside, you will have too much water. It's going to dilute your sodium. You're going to have hyponatremia, which causes brain swelling. And the other causes dehydration, which leads to hypovolemic shock. So let's talk about labs. This is where students either get it or they're kind of lost. Okay, so let's make this clear. Let's simplify it. So in SIADH, your sodium will be low. Your patient's going to have hyponatremia. Why? Because there's so much fluid inside, they're soaked with fluid, it's going to dilute the sodium. Their serum osmolality is low. So serum, the blood, is going to be low because they have so much water diluting the blood. The urine osmolarity will be high because they're holding in all of the fluid, so the patient's not urinating. So the urine is actually going to be concentrated. And that is why the urine specific gravity is also high because the urine is concentrated. Okay, so we said the sodium is low, serum osmolarity is low, Urine osmolarity is high. Urine specific gravity is high. Why? Because the body is holding on to water, diluting the blood, concentrating the urine. Now let's look at diabetes insipidus. The sodium is high, hypernatremia. Why? Because the patient is urinating too much. So it's pulling the fluid out of the bloodstream. It's causing um, the sodium to now, instead of being diluted, now it's concentrated. So that's where the hypernatremia comes from. The serum osmolarity, the blood, the concentration is going to be high because the patient is dehydrated because they're losing so much fluid. The urine osmolarity will be low because the patient is constantly urinating. So the urine is going to be not as concentrated, and the urine specific gravity will be low as well. Why? Because the body's losing water. The blood becomes concentrated, the urine becomes diluted. So, what you must remember, soaked inside is SIADH, diluted blood, concentrated urine, patient is soaked inside. Diabetes insipidus, dry inside. So your patient's going to have concentrated blood, diluted urine, and like I said, they're dry inside. This will really save you on exams. Now, let's look at your patient's presentation and what is actually, going to kill your patient. And so that's why it's so important for you to pay attention. In SIADH, the patient is going to present as confused, seizure activity, low urine output. So remember, hyponatremia, they're soaking all the water in. It's going to lead to brain swelling and it's going to lead to seizures. Okay, that is what's going to kill your patient. Too much fluid causes hyponatremia, which leads to brain swelling, which leads to seizures. Now, with diabetes insipidus, your patient's going to present with polyuria, they're urinating too much, polydipsia, they're going to be very thirsty, dry skin, hypotension. Okay, so what is killing your patient? Too much fluid loss, leading to hypovolemia, not enough volume, leading to hypovolemic shock. Now, let's look at this again. SIADH, the patient is retaining fluids, so they're soaked inside, and it's going to lead to a neuro emergency because, like we said, too much fluid dilutes the sodium, causes seizures. So it's a neuro emergency. With diabetes insipidus, there is a volume emergency because the patient is losing so much fluid, they are dry inside. Hopefully, you're starting to get it. Now, this is where the NCLEX kind of lives when we're talking about priorities. So in SIADH, fluid restriction. Remember, the patient has too much fluid. So you want to restrict their fluids. Monitor the sodium. We talked about it. Too much fluid dilutes the sodium, causes hyponatremia. So we need to monitor the sodium levels. Seizure precautions. The hyponatremia leads to seizures. And possible, you may see orders for hypertonic saline. And what that does is that it pulls the water, because the patient's soaked inside, so it pulls the water out of the cells into the bloodstream so it can go to the kidneys to be excreted out the body. So you look for those kind of orders. One thing with SIADH, you're not going to give fluids freely. We just said fluid restriction. Because the fluids are going to worsen the problem. They already are soaked with fluids. You don't want to give them anymore. Okay. Now, with diabetes insipidus, the priority is replace fluids. IV, I mean, I guess you could do it, oral, but IV, um, because they're losing so much fluid. We're going to monitor the urine output. You may see orders for desmopressin or DDAVP, which controls excessive urination. Okay. you're going to monitor the sodium because, with the patient being severely dehydrated, they're going to have hypernatremia. And as you're giving them fluids, you're going to monitor the sodium because sometimes maybe we can give them too much. And so now we're going from hypernatremia to hyponatremia. So it's going to be very important for you to monitor those sodium levels. So let's kind of lock it in. SIADH, the patient is soaked inside. So this patient is going to need fluid restriction. Okay. Diabetes insipidus, they're dry inside. This patient is going to need fluids. Hopefully it's working. Hopefully this is getting in you. Now, let's look at some traps. Traps with this, you're giving fluids for a patient that has SIADH. You're restricting fluids with a patient that has diabetes insipidus. You're mixing up the sodium levels. You can't remember which goes with which. And you're ignoring the urine concentration because that's really giving you a clue of what's going on with your patient. The NCLEX is not going to always give you the diagnosis. They'll show you the labs. They'll tell you what the urine output is. They'll give you some symptoms. Okay. And they expect you to figure it out. Okay. So let's recap. SIADH, too much antidiuretic hormone, low sodium because have too much fluid, concentrated urine because the fluid is staying in, it's not being excreted. So this patient needs fluid restriction and they are soaked. The patient is soaked with fluid. Now with diabetes insipidus, they have too little antidiuretic hormone, high sodium because they have excreted all of the urine, so they don't have enough fluid to dilute the sodium, so the sodium is going to be high. Their urine is going to be diluted because they are flushing out all of the fluid, so the urine is going to be diluted. And so for this patient, you're going to need fluids, and you may see orders for DDAVP. So diabetes insipidus, the patient is dry inside. Okay, so hopefully now you understand these water balance disorders. And so the next question, the next video is going to be about Addison's versus Cushing syndrome and what happens when cortisol levels go too high or too low. So, please keep on watching the videos and watch that video so you can understand that. And that's it. And that is it. Um, hopefully, like I said, you know the difference between SIADH and diabetes insipidus. Please like this video, subscribe to NurseEdScholar, leave some comments. Save this for your exams. I'm trying to break all of this down so you can understand it. Because here we just don't memorize. We are here to understand and to learn how to think like a nurse. Okay? So I'll see you next time. Happy studying from NurseEdScholar.